Hello, my name is Amanda Duddy, and my group members are Greta Staubly and Michelle Cardona. We are all P2s. Last semester in fall of P2 year, we took our psychiatry module, which we all had a strong interest in. In this module, we learned about many topics, including depressive disorders, anxiety disorders, substance use disorders, bipolar disorders, schizophrenia, ADHD, sleep disorders, and eating disorders. Today, we'd like to share some of what we learned, plus some of our own additional research, because we think it could be useful and beneficial information for healthcare professionals and patients to know and have a better understanding of. Here we have just our pictures and our contact information if anyone has any questions and would like to follow up after viewing the presentation. So the topic we chose and would like to discuss is antipsychotic medications and patient non-adherence. We know that patient adherence to medications is important for all pathologies, disorders, and disease states. Adherence is when a patient takes their drugs or medicine as prescribed, including dose, frequency, and timing. It was found that 30 to 50% of U.S. adults are non-adherent to long-term medications. This includes all medications, not just antipsychotics. This non-adherence could potentially lead to poor health outcomes for that patient population. We will touch on the negative consequences of non-adherence more later on. For antipsychotic medications specifically, we found a study that stated that 49% of major psychiatric disorder patients were not adherent to their psychotropic medications. It focused on patients with schizophrenia, major depressive disorders, and bipolar disorders, and found that the non-adherence rates were somewhere around 50% for all of them. They found that the major contributing factors to medication non-adherence were individual patient behavior, lack of social support, treatment and illness-related conditions, and health system factors. Today, we will be focusing on treatment plans and strategies to improve patient adherence, in particular to schizophrenic patients. Schizophrenia is a severe illness which affects all factors in a patient's life, including work, self-care, and interpersonal relationships. Patients with schizophrenia may have a combination of delusions, hallucinations, extremely disordered thinking and behavior, which impairs daily functioning. These symptoms are caused by abnormal dopamine activity in the brain. Patients with schizophrenia require lifelong treatment with medications, which makes adherence such an important aspect of the treatment regimen. Antipsychotics are the cornerstone of treatment for schizophrenia, which work by inhibiting those dopamine pathways in the brain and are effective in reducing psychotic symptoms, preventing relapse, and improving psychosocial functioning. So like I said, there are negative results associated with medication non-adherence, either by partial or even excess doses of the medication. The first is that there could be a breakthrough of symptoms. This will increase the risk of rehospitalization and relapse, as well as increasing the psychotic symptoms the patient could experience. This will in turn increase costs of the patient's treatment if they have to be hospitalized. This will also cause unnecessary adjustments to difficult medication regimens. Sometimes these medications are given by trial and error or in combination with other medications to have the best treatment outcomes for the specific patient. The patient will have to be reassessed for symptoms, and the doses of their medications may have to be titrated up again or decreased depending on the medication that they were taking. There are many factors that could contribute to non-adherence. Patients with schizophrenia often have comorbid conditions leading to polypharmacy, and they may not be able to keep track of all of their medications. Some of these comorbid conditions include cardiovascular disease, hypertension, and substance use disorders. It is found that there is a significant negative relationship between substance abuse, such as drinking alcohol and smoking cigarettes, with non-adherence. To improve this, screening of patients for substance abuse and offering brief motivational interventions for those in need of addiction rehabilitation services may lead to better adherence and outcomes. Patients with schizophrenia also experience stigma and social isolation. They may delay treatment because they feel embarrassed or scared, but this can lead to a higher risk for a more severe illness course. The duration of illness and the duration of treatment could also lead to non-adherence. Patients might feel like they've been on a medication for a long time and like they don't need it anymore, but like I said before, schizophrenia does require lifelong treatment. Also, the patient's location could lead to non-adherence. Patients who live in rural areas had higher incidence of non-adherence due to the longer distance to healthcare facilities and lack of services and low community awareness regarding the treatment of mental illness. Finally, the cost of the medication becomes an issue as well. The patient may be on multiple medications and cannot afford them. It is also hard for schizophrenic patients to hold a job for a long period of time due to either a breakthrough of symptoms or the need for hospitalization, so they might not have sufficient income to afford the medication each month. The high rates of medication non-adherence among these patients taking antipsychotics has led to the creation of novel dosage forms. For patients who cannot swallow or need lower doses, there are oral solutions, suspensions, and elixirs available. There are also capsules, immediate release tablets, orally disintegrating tablets, and sublingual tablets. There are extended release tablets or transdermal patches, which could be convenient for patients with no history of intentional non-adherence. And finally, we have the injectable oils and long-acting injectable antipsychotics, which is going to be our focus for the rest of this presentation. These dosage forms are convenient for patients with a history of non-adherence, since they can last for 2 weeks up to 6 months. And Greta will be the next speaker, touching more upon this.
A solution to non-adherence would be to use long-acting injectable antipsychotics, also known as LAIs. Long-acting injectable antipsychotics improve adherence to antipsychotic medications. However, they are not only recommended for patients with adherence problems, they are also recommended for patients just to improve ease of use. It is favorable because they have less frequent administrations. They're usually given between 2 weeks, every 2 weeks, to every 6 months, which can be very helpful and beneficial for all patients. These medications are given either as intramuscular, as in into the muscle, but there are also some subcutaneous formulations. It's important that oral tolerance is established first before long-acting injectables are used. So here are some of the current and available long-acting injectable antipsychotics. The first generation I listed here, along with the second generation, including their generics and their brand names. Some advantages of long-acting injectable antipsychotics are that no oral daily medication is required. It may also identify non-adherence in patients. It definitely will increase the convenience of administration with only having to have the medication injected every 2 weeks to 6 months. They may also be able to prevent hospitalizations in the future, as there will be more interactions between the patient and the caregiver, being able to provide more treatment as needed. Some disadvantages to long-acting injectable antipsychotics is there's less dosing flexibility, as they have to be given every 2 weeks or every 2 months, but it has to stay on that schedule. There's also a slower titration of dose, so that it may take a little bit longer to reach that therapeutic dose. Patients can't take their medication from the comfort of their own home. They will have to travel to healthcare sites to obtain each dose. Another problem could be patients' fear of needles, which is often a huge problem in healthcare. There is a high cost to these long-acting injectable antipsychotics, which may not make them accessible to all. And there is also a stigma of having long-acting injectable antipsychotics as your medication. Some side effects that patients might experience are generally less severe than the oral formulations of the antipsychotics. They may experience injection site reactions, which are common, including injection site pain, swelling, and rash, but those often occur in less than 5% of patients. There's less fluctuation of the serum drug levels due to a more stable drug receptor occupancy, so that can contribute to the lessened side effects. Also, there's a higher bioavailability, so a lower effective dose may be identified, which can also help to lower the side effects. Now we're going to talk about the dosing and its importance.
So now I'm going to talk about first generation long-acting injectables and their dosing. including haloperidol and fluvenazine. So for haloperidol, the initial dosing is going to be 10 to 20 times the daily dose, and the max dose daily is going to be 100 milligrams separated by 3 to 7 days. So for example, if someone was taking an oral dose of 15 milligrams, we want to give day 1 100 milligrams, and day 4, for example, their other 50 milligrams that they had left. Their dosing interval is going to be every 4 weeks, and the goal for the oral overlap is going to discontinue their oral medication within 1 month. For fluvenazine, the initial dosing is going to be 12.5 milligrams for every 10 milligram oral dose, and the dosing interval is going to be 2 to 4 weeks, depending on their oral dose. Their oral overlap will be. For second generation, the Abilify Maintaina is going to be an initial dose of 400 milligrams, and the interval is monthly, and the overlap is going to be for 14 days. The Aristata, their initial dose depends on their oral dose, and the dosing interval is also depending on that initial dose that they're taking, and their oral overlap is going to be 21 days for just regular Aristata, and then Aristata Initio is going to be 675 milligrams once. And then olanzapine pamoate is going to be an initial dose of 150 to 300 milligrams every 2 weeks, or 405 every month. And then the dosing interval, again, is depending on that initial dose. And the oral overlap is going to be to begin oral tapering after that first injectable. Same with Invega Sustenna, Invega Trinza, and Invega Half-Ura. For Invega Sustenna, it's going to be 234 milligrams day 1, and day 8 you want to give 156 milligrams, and the interval is going to be monthly. Trinza is depending on their oral dose, and it's going to be every 3 months, and Half-Ura is going to be every 6 months, which can be good for adherence as well. And Risperdal Consta is going to be 25 milligrams IM every 2 weeks, and that oral overlap is going to be a 3-week overlap. And the Proceras is 90 or 120 milligram, and this one's going to be sub-Q, not IM. And the interval is every month, and the oral overlap is not required. For pharmacokinetics, we wanted to talk about this because we thought it was really interesting, especially compared to other medications that are out there. So it follows a flip-flop pharmacokinetics. The half-life on this is going to reflect the release or absorption rate constant, and the time to peak is going to reflect the elimination rate constant. Usually for medications, the absorption rate constant is going to be greater than the elimination rate, but for flip-flop pharmacokinetics, which the long-acting injectable usually follows, the absorption rate constant is going to be less than the elimination rate constant. And roles of the pharmacist, which are important, is that reduce administration frequency of these LAIs can improve patient adherence and reduce hospital readmission rate, and this leads to an improved patient health outcome and quality of life, and this is especially important for people taking LAIs because they're so non-adherent with their medication, and their oral tolerance should be established prior to that administration of an LAI. The patient and doctor should always be aware of those dosing conversions and intervals in the route of administration, if it's IM or sub-Q. And the cost also has to be considered when discussing patient treatment and adherence, which I'll talk about. So for cost considerations, which is important especially with adherence too, is that the LAI antipsychotics are generally more expensive than oral antipsychotics. The price of newer long-acting injectable antipsychotics are going to be way more expensive or greater than older antipsychotics. However, when we compare healthcare costs, The LAI group had fewer hospital days and ER visits with higher number of prescription fills. So this chart is just showing kind of a comparison of the prices between a long-acting injectable versus an oral med. So the discontinuation rate is way lower with a long-acting injectable. The inpatient cost is also lower, especially because there's less readmission because there's less or more adherence when you're using a long-acting injectable. Also, the monthly med cost is going to be higher, but when we look at the total medical cost, it's pretty similar. So that's something to consider. And then these are our sources.